The most important thing in illness is never to lose heart. Feed your faith and your fear will starve to death. Cancer is a word, not a sentence. When you think about it, what other choices is there but to hope? We have two options, medically and emotionally. Give up or fight like hell. Today, we are going to continue fighting against colorectal cancer, a disease easy to prevent and to treat when detected early. Good evening. Tonight it's my pleasure to welcome Dr. Abdel Alo, who is well known as a colorectal surgeon in Northwest Ohio, specifically discussing the colorectal cancer, especially with that we are going to have that colorectal cancer month very soon. Thank you for being here, Dr. Alo.
Thank you. Appreciate your call.
I would like you to start defining or telling us what does it mean, colorectal cancer?
Well, cancer obviously is an abnormal growth which grows inside the colon, and the last portion of the colon is the rectum. So it's all one category. It's the cancer abnormal growth that starts at it can start actually in any part of this organ, which is about 5 feet long from the beginning with the junction of the small intestine to the rectum towards the end. So
technically it's involving the large bowel and the rectum for most of those patients.
Correct. The large intestine and the rectum.
And the word cancer is devastating to any family or to any patients. And the most common information we ask, okay, why me? If there's any specific group of population which is they are at higher risk to develop colorectal cancer?
Correct. First of all, it's cancer obviously, and it's devastating, but colorectal cancer specifically, nobody should die from colorectal cancer because it's easily preventable. In general, the people who are the highest risk are the people in general like over 50. And if there's any family history of somebody like a first degree family, like parents, siblings in the family who had cancers or even had polyps, which are considered precancerous, those people also would be considered higher risk. Or people who are really inactive, don't do too much exercise and so on. Or people who have, the diet is not the best diet, like high fat diet and less fiber, less grains, whole grains, and so on. So these are in general considered high risk.
So when we're talking about someone to discover it at the early stage as a preventive measure, we need to understand how can we prevent it? What are the measures, in your opinion, which is we can do screening-wise to prevent ourselves from having that disease?
That's an actual excellent question, because I said earlier, nobody should die from colon cancer because it's easily preventable. The general recommendations is that with average person on the street with no family history, no symptoms, everybody at the age of 50 should have a screening colonoscopy, which is a test done as in the hospital or outpatient facilities under sedation. The test itself only takes about 10-15 minutes, and really that saves lives. One thing I want to mention, colorectal cancer is the second leading cause of cancers in the country after lung cancer. In the country in general, in the USA, 55,000 people die every year from colon cancer.
Wow.
So simply by doing this screening test, that prevents cancer. Unlike many other cancers which may not be easily preventable or detected, this could be caught much earlier, because to go a little step further, almost all colon cancer starts with a little growth called a polyp. That's how it starts. And to go from one cell to become a cancer takes 7 to 10 years. So if you do the scope and catch the polyp early and remove it, basically we have prevented a cancer.
And this is the type of polyp that we want to look for in a screening exam and remove. By removing a polyp like this, you prevent it from ever having the chance of turning cancerous. This polyp causes no discomfort, and the patient has no idea that it's even in there. The white catheter that you see that's coming out is actually coming through a channel in the scope known as the biopsy channel. And it's being used right now to just investigate how this polyp attaches to the wall. And what you can see is that the polyp is attached by just a little bit of normal tissue, what we call a little stalk. And we're going to use this snare, which is a catheter that has a loop of wire around it, to extend the wire out around the base of the polyp and then put electric current through that wire. You see the wire coming out now, and it's been surrounding the bottom piece of that polyp. We're going to now close that snare, and the patient feels nothing of this as this is being done. There's absolutely no nerve endings there. Now electric current is going to be put through that snare, and you're going to see the polyp start to turn purple and fall off. The reason it fell off is that the wire cut through the base and cauterized at the same time that it cut, so there's no blood or bleeding. We're using a water jet now to irrigate or wash that area where the cut had been made, and as you can see that the tissue looks completely normal and healthy there. So it's been completely removed, and we'll send the polyp to pathology.
So the polyp is not necessarily a cancer, right? It's like early stage of growth could convert and become a cancer.
Exactly. Some polyps, basically, some don't even grow to become cancer.
Okay.
But some polyps are considered precancerous. Any polyp, of course, when I see any polyp should be removed.
Sure.
Because you can't tell. Most of the time you can't tell, but still you have to send it to the lab to analyze it. So the so-called precancerous polyps, those are the polyps that will grow if left unnoticed or undetected. They will grow to become a cancer.
And colonoscopy is the only way to detect that problem.
Well, actually, let me put it this way, is the golden standard.
Okay.
There are some other ways. May I go one step back, actually. In general, all family physicians, primary care physicians, would usually do what's called the Hemoccult test positive, Hemoccult test. They check the stool if there's any blood in the stool. Doesn't mean cancer, but it's one way to convince the patient to go and be checked. The point is, you don't want to wait until you start having symptoms. Because when you start having symptoms, usually it's a late disease. Sure. It's a late situation. So start when there's no symptoms and ask your family doctor to, let me put this actually, most of insurance companies nowadays, when you hit 50, they will send you a letter to tell you, go have your screening colonoscopy.
Okay.
And simply put, don't let fear kill you. The fear of colonoscopy. It's really a simple procedure.
That's a great point, actually, and that's what we want to emphasize on. If your family doctor or your insurance telling you that at age 50 you need that colonoscopy, it's not necessarily you are having cancer or you're going to have cancer, as much as to prevent you from developing that disease and end up having the devastating problem in the future. And that's why Dr. Alo is suggesting that it's a necessity to have that first test at age 50 or around age 50 to prevent yourself from that kind of problem.
The other point I want to add to that, actually, if there's a family history, if somebody's in the family had cancers or polyps, actually we start earlier.
Sure.
It doesn't have to wait until the age of 50, especially if both sides of the family have history of colon cancer or those types of polyps. Actually, we start earlier, maybe at the age of 40 or sooner. In general, also, heaven forbid that somebody in the family at the age, let's say 52, have colon cancer. We recommend that the children or the first degree relative, they should start 10 years earlier. So at the age of 42, go ahead with your colonoscopy. because of the family history here.
Wow.
But if average risk, anybody average risk, we start at the age of 50.
That's a great point. Yeah. Which is bring us basically to, let's assume, to my understanding, some of the colorectal cancer, the way you reported, they could be younger than 50. So what are the most common symptoms the patient could experience as a warning sign that I should go and have the colonoscopy or have my family doctor check me to be sure, or the colorectal cancer specialist to check yourself and avoid the advanced stage of that cancer?
Okay, that's a good question actually. The symptoms are many symptoms, but doesn't mean that everybody has symptoms, doesn't mean it's cancer. But if there's any symptoms, for example, like rectal bleeding, change in bowel habits, like diarrhea, constipation, feeling of pressure, like you go to the bathroom, but you still feel like you're not empty, or cramping, or pains, or fatigue, or loss of appetite. All these things are, like a red flag. Go get checked. But again, doesn't mean it's cancer, but it's better always to be checked, especially again if there's a family history or at that age. One point I want to mention also, people who get colon cancer at an early age, when I say early, I mean less than 50, usually it's very aggressive.
Okay.
Usually it's very aggressive. So we take things for, take it seriously and get checked this way for a peace of mind and of course to prevent cancer. As simple as that.
Now, when you do that first screening test at age 50 as preventive measure, to my understanding, you have to repeat it also, right?
Yes.
How often you repeat it if there is no problem, and how often you repeat it if there is some evidence of polyps or some other pre-growth?
Excellent question. Most insurance companies, including Medicare, they tell you if there's a screening colonoscopy, if you don't find anything, you have to do it once every 10 years.
Okay.
Because I mentioned earlier, colon cancer is very slow growing. But unfortunately, in my practice, we see this every day. You see cancers, or you catch cancers, who people have had their colonoscopies less than 10 years ago. You still see cancer, so it's not, solid that you every 10 years. Depends on the symptoms and other factors. But in general, yes, once every 10 years, unless there's a polyp. If there's a polyp and that polyp proves to be the type which is considered precancerous, then we go every 3 years.
Every 3 years. Okay.
Every 3 years.
If there's any other test which is a patient can utilize other than the colonoscopy, I mean like for screening or for follow-up of colorectal cancer in general?
For screening, there are, it used to be again, what they do the stool exam for the blood. They also do a barium enema, which is as extensive as a colonoscopy because they have to have the same bowel prep, and they have to inject air and barium in the colon to take an X-ray. And if it shows a polyp or something, you still have to do a colonoscopy anyway.
Sure.
So that's number one. The other one, which is called the virtual colonoscopy, which is an advanced X-ray, like CAT scan. That's not available in this area, but I know it's available in other towns. That's simply, again, an advanced CAT scan. It could show some polyps. The point is, again, same prep, maybe same discomfort, and if it shows something, you still have to have colonoscopy anyway. But if somebody really scared, they don't want to go through the colonoscopy, those are available, either barium enema or a virtual colonoscopy.
Okay.
Screening programs aim to identify individuals with cancers at an earlier stage and allow for treatment before growth and spread has occurred. It also allows for detection of precancerous growths, such as polyps, before the cancer is even developed. Several screening techniques for colon cancer have been used. As cancers grow, they may bleed. Small amounts of blood are not necessarily visible within the stool. Testing stool samples for occult blood may indicate the presence of a cancer within the colon. Several trials have shown benefit from the use of this test as a screening tool. This test should be part of a regular exam. However, it will only detect cancers within the reach of the examining finger, cancers of the mid and lower rectum. Modern scopes have had several improvements. They are thinner and more flexible with better fiber optics, allowing sharper images. In addition, the instruments allow the use of additional devices for a variety of functions, such as snares for polypectomies, forceps for biopsies, and other injection devices. Flexible sigmoidoscopes are 60 centimeters long and are able to detect about 65% of all polyps. Upon the discovery of an adenoma, a colonoscopy is usually required to evaluate the proximal bowel. Case control studies have shown benefit in terms of reduced colon cancer mortality and incidence. However, they only evaluate the distal end of the colon. A colonoscopy is the gold standard in terms of screening. A scope enters the rectum and is extended through the entire colon. This test will identify almost all cancers and most pre-malignant polyps. It also allows for the removal of smaller growths. This test only has to be repeated every 5 to 10 years if no polyps are present. Virtual colonoscopy is a new technique that uses computed tomographic or magnetic resonance images to produce computer-generated images of the colon. Patients still require bowel prep and have air insufflated into their colons. In experienced hands, this test is as good as a colonoscopy in detecting cancers and larger polyps.
Join me at oneheart.org and find out how you can help those patients with heart disease who are in need. Go to oneheart.org.
Bare minimum is done almost at every hospital, but the virtual colonoscopy will be like somewhere out of Toledo. It's not available here yet.
I understand.
Yeah.
And when it comes to the patients, you are suspicious of something and polyps, and you send it to pathology and you find that it's cancerous. The first question the patient asks, how advanced? How can you define the advancement of that growth for that cancer? So we can just give an idea to the patient about those stage 1 or stage 2, I mean, in general.
That's exactly what happens. You do colonoscopy and find some biopsy that comes back with cancer. First thing, again, where am I? What's going to happen to me? Should I write my will? All these things. Over the last 20, 30, 40 years, we have come a long way. It used to be when there's the word cancer, that means I'm dead. Yeah. It's not that way anymore. Obviously, it still depends on the stage. Unfortunately, even up today, we diagnose many patients with stage 4, which is the worst. Mm-hmm. So simply, if you find the cancer, first step we do is to do the staging. Staging, first thing we'll do a CAT scan, mm-hmm. or nowadays what's called a PET scan, which is like a scans the entire body to show if there's any spread somewhere else. And it used to be CAT scan of the abdomen, pelvis, chest X-ray, and lab work, mm-hmm. all these things to see if he or she has been losing blood. So all these preliminary studies, we have to do everything.
Sure.
And the second thing to do the PET scan, and then now we have a rough idea of what stage it is. Mm-hmm. If it's gone to the liver or the lung or somewhere else, obviously that's an advanced stage. Even in the advanced stage, again, it's still with the new chemotherapeutic agent and radiation treatment and surgery and so on, still the prognosis is not as bad as it used to be. Okay, it has improved to a good extent.
Sure.
Okay, so that's in basic general. So we have to, the final staging, as a matter of fact, the final actual staging will not be till after the surgery.
Okay.
When you remove everything out, check for lymph nodes and everything else, the area. Mm-hmm. But we have a good idea with a PET scan and MRI sometimes, ultrasound, many things that we can get a rough idea or a good idea about the stage of the disease.
That's why the first step for that stage is the removal of those polyps by a simple colonoscopy. Exactly. It's better than having the whole colon removed because of advanced cancer. And that's really what we're trying to emphasize on, how important that screening test to everyone, every man and woman at age 50, because it's so important to prevent them. It doesn't matter if they have family history or not. Probably will let the family doctor make a determination if they need to have that earlier or not. Now, Dr. Alo, when it comes to the treatment, definitely removal of the polyps, one, but when it comes to surgery, I mean, which is like different stage of the cancer,
Right.
I understand that in Northwest Ohio, we are blessed with having enough qualified centers to take care of that problem.
Absolutely, we have enough qualified. It's a teamwork between the surgeons and the oncologist and the radiation oncologist. With this teamwork, we have excellent teams, you know, in Northwest Ohio, so no question about that. So with this teamwork, the prognosis had improved significantly. Okay, obviously there's a minor difference between colon cancer and rectal cancer, because most of colon cancer you can remove it without colostomy, but the rectal cancer, if it's really, really low, nothing left there to hook it up, they may end up with a colostomy. But again, I always tell my patients, colostomy does not mean the end. And I tell my patients, you will be surprised how many people around you working and living their normal life and they have a colostomy, you don't even know it.
Okay.
So it's, you know, that's one difference. But with the rectal cancer, we may lose the rectum with a colostomy. But again, that's not the end. But again, with the radiation, with the chemo, also the number of colostomies have also gone down. It used to be we do a lot of colostomies,
because
you know,
it's discovered early.
because discovered early, and with the chemo and radiation, downstages the cancer, downstage, and give us enough length, not always, but you know, give us enough length so we'll be able to hook them back together without having to wear a bag.
That's great.
So that's also, and we have excellent, you know, teams in this area that we, and again, this is a teamwork. It's not like one entity or one person. It's a teamwork, everybody working together to help save the.
So the most important question the patient, including myself, has, for example, how can I prevent myself from having colorectal cancer by, if there's any specific kind of food I can eat, any specific kind of vitamins I can take to prevent myself from having that kind of problem?
Well, that's again an excellent question. I alluded to it partially in the beginning. Eating high fiber diet, a lot of vegetables, whole grains.
Okay.
That's in general, you know, cut down or stop a high fat diet. Okay, exercise. Okay, and screen.
Sure.
So that's basically, you have, like I said earlier, nobody should die from colon cancer.
What about smoking?
Smoking. I mentioned, even alcohol.
Alcohol.
Smoking and alcohol are also known to be also a factor in colon cancer too.
When it comes to the future, we always talk about research and new discoveries. And to my understanding, there's a lot of things going on when it comes to the colorectal cancer field. Do you mind to shed the light for us about some of those points?
Well, yes, actually, especially genetics, the genetic counseling. Also, one of the screenings not out yet.
Yes.
Instead of doing the blood test, they can screen the genes in the stool.
Wow.
So they can catch the gene in the stool that, you know, but this is whether there's cancer or not, or prone to be cancer or not. So that's in the progress, and maybe out in the next few years. But yes, that's a great possibility.
And I understand that could detect the cancer far years ahead of the time you discover the polyps. Even.
Right.
That's
Yeah,
really
so
tremendous advance.
That's coming up maybe in the next few years.
That's excellent.
Yeah.
Excellent.
Yeah.
I found out I had colorectal cancer when I went for the FIT test kit, and subsequently it came back positive. So I was advised by the doctor to go for the colonoscope, and that's how I found out I had colorectal cancer. When I was diagnosed with colorectal cancer, I was in total shock because I never knew that. You know, I was always very active. I played badminton. I was always traveling here and there. And never in my life would I ever imagine that I had colorectal cancer. Colorectal cancer has a big impact on my life because my quality of life has gone down. I travel less now. I used to play 3-4 times of badminton a week. Now I cut it down to once a week. I used to walk long distances, but now I take short walks. I travel less now, no more long haul travels for me, only short distances. But certainly one thing is for sure, my wife has been an inspiration, and my family has supported me a great deal, and I'm very grateful. My advice to my friends and fellow Singaporeans is to go for colorectal cancer screening, because colorectal cancer affects everybody. It has no symptoms. It can affect the poor, the rich, the tall, the short, the ugly and the beautiful. So go for your screening as soon as possible on a regular basis.
The large intestine, or colon, is a part of the gastrointestinal tract that makes and stores stool. It includes the ascending colon, transverse colon, descending colon, and the sigmoid colon. The cause of cancer is an uncontrolled multiplication of cells lining the colon. Before a true cancer develops, it usually begins as a non-cancerous growth called a polyp. Certain people can have multiple polyps in their colon, which are inherited genetically. Over a period of several years, a polyp has the potential to become cancerous. A cancerous polyp grows rapidly in size, eventually breaking through the wall of the colon and spreading through the tiny channels called lymph vessels. The cancer can also spread through blood vessels to other parts of the body. Symptoms of colon cancer are blood in the stools, a change in bowel habits, resulting in either more constipation or diarrhea than normal, abdominal pain, unintended weight loss. Treatment. Treatment varies depending on the stage of the disease. Some patients will need surgery to remove the diseased segment of the bowel, followed by radiotherapy or chemotherapy.
I really appreciate all of the information. That was very helpful, very educating. And I can tell you guys, I'm going to schedule my colonoscopy very soon.
But you have to be 50 first.
Oh, thank you. I like that. I like that. Thank you very much. Thank you so much for being here.
Okay, thank you.
The fact is no one should ever die from colorectal cancer. There are over 130,000 cases of colorectal cancer diagnosed in the United States each year, and over 50,000 deaths from that disease. It's the second leading cause of cancer death. It's a cancer that can be prevented. Start by knowing your family history. Discuss option with your family doctor, but the most important thing, schedule your colonoscopy at age 50. Because remember, time waits for no one.